In the name of God, today I want to talk about the placenta, umbilical cord, and fetal membranes. The first of all, I started from the placenta. Placenta is a temporary organ formed during pregnancy. It forms as an important circulatory link between the mother and fetus. The placenta consists of two major portions: the maternal part of the placenta that derive from the decidua, and I will talk about the decidua, what is the meaning of the decidua. And the second part is a fetal part of the placenta that's derived from the chorion. As you know, the change in the trophoblast is happen in the second week by formation of the primary villi, secondary and tertiary villi, but the tertiary villi is formed in the third week of the development. And we have one new structure that name is outer cytotrophoblastic shell, lacunal space, and decrease of placenta barrier and until the beginning on the 4th months. But by details, first of all, I started by decidua. As you remember, the placenta has two parts, the maternal part and the fetal part. The maternal part is named is a decidua, and which part of decidua? Decidua basalis. But the first of all, I want to talk about the definition of the decidua. Decidua refers to the functional layer of the endometrium. It means in this area, dot point area, refer to functional layer of endometrium after implantation of the blastocyst stage of the fertilized ovum. The term decidua, the decidua meaning falling off, is used for this part of endometrium as it separates from the remainder of the uterus and fall away during childbirth. After the implantation, here, this is a uterine cavity, this is the site of the implantation, and this is the epithelial layer of the endometrium. This is a functional layer of the endometrium, and when the embryo is implanted in the functional layer, we have a change in the endometrium in response to the embryo, and this change is conversion of the stroma cells of the endometrium to the decidua cells. These changes happen due to effect of increasing progesterone level in the maternal blood. The stroma cell of the endometrium, it means that stroma cells in here, get converted into decidua cells by becoming enlarged, vacuolated, and filled by glycogen and lipids. It means that decidua cells is a large cells that filled by the glycogen and lipid droplets. The stored glycogen and lipid are the source of nutrition for embryo till placenta takes up this function. What we divided the placenta into three parts. Decidua basalis or decidua plate refer to the part where the maternal part of placenta is to develop. It means that that's part of the decidua situated in the embryonic pole. This is the embryo, and this part that opposite to the embryo, we say that embryonic part of the decidua, this cells making a decidua basalis, and this part of the decidua take part in the formation of the placenta. But we have a decidua reaction in the another part of the endometrium. In here I show it. That part of the decidua situated overlie embryo and separated it from the uterine cavity here. This part of decidua separated the embryo from the uterine cavity. This part is named is decidua capsularis. And remaining part of decidua, it means these two sides, Its name is decidua parietalis. It's referred to part of decidua lining the rest of the uterine cavity. In conclusion, decidua bardalis opposite the embryo, decidua capsularis between the embryo and uterine cavity, and the rest of the decidua cells in the uterine cavity, its name is decidua parietalis. Another part of the placenta, as you know, it's come from the fetus. That name is chorionic part. It means that the fetal part of placenta is developed from the chorion. As you know, the chorion is a membrane formed by fusion of the trophoblast cells with underlying extraembryonic mesoderms. Here, as you remember, in around the embryo we have a here extraembryonic mesoderms that covered by cytotrophoblast cells is not shown here. These two layers together making the chorionic plates. And now I want to talk about how the chorion is formed. I want to talk about the formation of the villi and intervillous space in the chorion, and formation of the chorionic frandosome. As described in the pre-embryo stage of development, the trophoblast differentiated in two layers, cytotrophoblast and syncytiotrophoblast. And if you remember, in the 9th day of the development, the small cavity is appear in the syncytiotrophoblast as a name of the lacuna. And when the lacuna is developed after the short day, it means that around the 11 to 12th day of the development, the first communication between the mother capillaries, that name is a sinusoid, it's happened between this capillary communication with the lacuna, and we say that this days is a uteroplacenta circulation. Here you can see that for the lacuna, and this is a villi, but for the formation of villi we have some stages for the formation of the villi. The formation of villi take place in the 3 stages. First of all, the primary villi is formed. In the second step, secondary villi is formed, and finally the tertiary villi is formed. But how the primary villi is formed? In the second week, the cells of the cytotrophoblast proliferated locally and penetrated into trabeculae formed by syncytiotrophoblast. Such cellular mass surrounded by layer of syncytium are called primary villi, and surrounding lacunar space filled with maternal blood are now called intervillous space. Here is an intervillous space because this one is a one villi and this one is another villi, and this lacuna here we can say that this lacuna is intervilli space. The secondary villi are formed in the early 3rd weeks. This occurs by penetration and growth of mesenchymal cells into core of the villi, formed in the 2nd week of the developments, because here we have a cytotrophoblastic cell. When the cytotrophoblastic cells come in the core of this villi, we say that this is a secondary villi. And tertiary villi are formed by the end of the 3rd week. This occurs by differentiation of mesenchymal cell of core of secondary villi into capillary and blood cells. It means that when the blood capillary, as you see in here, is appear in the core of the villi, we say that this is a tertiary villi. Now in this picture you can see only the tertiary villi, because you can find the blood vessels and blood cells, the core of the villi. Okay, that's part of the villi. If you look at the whole of the embryo, in the embryonic pole, the tertiary villi is developed very well, and finally we say that this like a bushy chorion, or we say that this is a tertiary villi, and the shape is like a specific picture. We say that this is a chorionic frondosome. Frondosome means bushy. A small tree in the desert, that name is a bush. Okay, and because this is resemble of this bush like trees, we say that chorionic frondosome. And another pole, an abembryonic pole, the opposite side of the embryo, here you can see that the villi is not developed very well, and we say that this is a smooth chorion, because we doesn't need two villi in this part, in the opposites of embryo. And in conclusion, we say that the placenta has two parts. The maternal part is name is decidua basalis, and the fetal part is name is chorionic frondosome. Now you can see that the chorion is formed. During the 4th and 5th months, the decidua form a number of decidua septa, which project into intervillous spaces but do not reach the chorionic plate. Okay, here it means that, like these pictures, this is decidua septa, as you see here, is not received to the chorionic plates. Okay, that come from the maternal side. These septa have a core of maternal tissue. Here this is a maternal tissue, but their surface is covered by a layer of syncytial cells. This is a syncytial cells, so that all time a syncytial layer separate maternal blood in intervillous lakes from fetal tissue, the villi. As a result of septum formation, this is a septum and septum and septum, the placenta is divided. In this picture you can see here, the placenta is divided into a number of compartments or cotyledons. Each part here is named is a cotyledon, and here the border of each cotyledon is formed by the decidua septa. Because decidua septa do not reach the chorionic plate, contact between intervillous space in the various cotyledon is maintained. As a result of continuous growth of fetus and expansion of the uterus, the placenta also enlarge. Okay, in the full-term placenta, placenta is discoid with a diameter about of 15 to 25 centimeters, is approximately 3 centimeters thick, or thickness is about 3 centimeters, and weight about 500 to 600 grams. At birth is torn from the uterine wall, and approximately 30 minutes after birth of the child is expelled from the uterine cavity as the after birth. When the placenta is viewed from the maternal side, you can see about 15 to 20 slightly bulging area. It means 15 to 20 cotyledons covered by thin layer of decidua basalis are clearly recognizable. This is the decidua basalis here. In fetal surface of the placenta is covered entirely by chorionic plates. You can see here the chorionic plates covering toward the umbilical cord. The chorion in turn is covered by amnion. Here is covered by amnion, the chorion covered by amnion. Attachment of the umbilical cord is usually eccentric and occasionally even marginally. Rarely, however, does it insert into the chorionic membrane outside of the placenta here. This is an abnormal situation, and we say that this is a filamentous insertion. And about the circulation of the placenta, cotyledon receive their blood through 80 to 100 spiral artery that pierce the decidual plate and enter the intervillous space. And collectively, the intervillous space of the mature placenta contain approximately 150 milliliters of blood, which is replenished about 3 or 4 times per minute. The blood move along the chorionic villi, which have a surface area of 4 to 14 square meters. The placenta exchange doesn't take place in all villi, however, only in those that have fetal vessels in intimate contact with the covering syncytial membrane. Here we have a placenta membranes. What it means from the placenta membrane? The placenta membrane, which separate maternal and fetal blood, is initially composed of 4 layers. In this picture you can see that structure of villi at various stage of development. Before the 4th month, this barrier consists of the 4 layers, as you see here: syncytiums, this one, cytotrophoblasts, connective tissue, and endometrium. Started syncytium in the outer layers. The second one, the cellular layer, is cytotrophoblast. The white color is a connective tissue, and this one is an endothelium of the fetal vessels. We say that before the 4th month of development, the placenta barrier consists of these layers. But during the 4th month, in many small villi, the wall of the capillaries is in direct contact with syncytium. You compare these 2 pictures, and we say that the barrier diminished to 2 layers, syncytium and endometrium. Is exactly it's happened for the fast in the circulation. As a result, because the maternal blood in the intervillous space is separated from the fetal blood by chorionic derivative, the human placenta is considered to be a hemochorial type. Normally, there is no mixing of maternal and fetal blood. However, small number of fetal blood cells occasionally escape across microscopic defect in the placenta membrane. In conclusion, you can see that the chorion has chorionic frandosome and leaf or smooth. Only the frandosome take part in the formation of the placenta, and decidua divided to 3 parts, but only the decidua basalis take part in the formation of the placenta. And another point that is important, in some texts we say that this is a chorionic, this is anchoring villi, and this villi, like a tree, his name is a free villi. This is a coronal section of this villi. You see that this is a chorionic villi or a stem villi, and this is a free villi, and exchange of blood cells take place in the free villi in the humans. What about the function of the placenta? Main function of placenta are exchange of the gases. It takes place by diffusion, facilitated diffusion, active transport, and pinocytosis. Exchange of the nutrients and electrolytes. Transmission of maternal antibodies, especially IgG, and passive immunity against diphtheria, smallpox, measles, and not against chickenpox and whooping cough. Okay, and another role of the placenta is secretion of the some hormone, or hormone production is take place also by the placenta. During the first 2 months of pregnancy, the sensitio trophoblast also produces human chorionic gonadotropin, or HCG, which maintains the corpus luteum. This hormone is HCG, it means the HCG is exerted by the mother in the urine, and in the earliest stage of gestation its presence is used as an indicator of pregnancy. Another hormone produced by the placenta is somatomammotropin. Formerly its name is placental lactogen. It is a growth hormone-like substance that gives rise to the fetus priority on maternal blood glucose and make the mother somewhat diabetogenic. And also the placenta secreted small corticotropin hormone and human tyrotropin hormone, and again the placenta synthesizes a small amount of cholesterol and the fatty acids. You can see that the placenta barrier of the 4th month, that as I told you, it consists of the 2 layers, syncytium and endothelium of fetal capillary. This is a role of summary of the role of the placenta. And sometimes we have some abnormality or disease, that one of them is name is erythroblastosis fetalis and fetal hydrops. What that means, as you know, some fetal blood cells escape across the placenta barrier. There is a potential for these cells to initiate an antibody response by the mother's immune systems. Okay, as you know, in high school, the basis for this response is the fact that more than 400 red blood cells antigen have been identified, and although most do not cause problem during pregnancy, but sometimes the antibodies will attack and hemolyze fetal red blood cells, resulting in hemolytic disease of fetus and newborn. Previously, the disease was called erythroblastosis fetalis because in some cases severe hemolysis stimulates an increase in production of fetal blood cells called erythroblasts. And here you can see that severe of anemia occur in a few cases, such as hemolytic disease of fetus and newborn is a more appropriate terminology. In rare cases, the anemia becomes so severe the fetal hydrops means edema and effusion into body cavities occur, leading to fetal death. And you can see here about the erythroblastosis fetalis and hydrops. When does it occur? When mother Rh negative and fetus be Rh positive. How does it occur? Fetal RBC into the maternal system at birth. Treatment, intrauterine or postnatal transfusion for affected. Prevention, antibody screening and anti-D immunoglobulin. And another part of fetal membrane is amnion and umbilical cord. The amnion is oval line of the reflection between the amnion and embryonic ectoderm. We say that amnio-ectodermal junction here. This is the amnion and this is the ectodermal surface of the body of embryo. Here his name is amnio-ectodermal junction. Here we have one primitive umbilical ring in the amnio ectodermal junction. This is a large defect in the anterior body wall. Its name is a primitive umbilical ring. If you look at these rings by detail, you can see that this is rings. You can see that some structure coming out from the body of embryo, or vice versa. Some things go to the embryo. Here this is umbilical vessels. As you know, we have a 2 artery and 1 veins. This is a loop of the intestines, intestinal loop, the vitelline duct, and this is a yolk sac. And this cavity here, that yolk sac is situated in it, its name is chorionic cavity. Here is connecting stalk, and this is the allantois. Okay, you can see here the connecting stalk containing the allantois and abdominal umbilical vessels consists of 2 arteries and 1 veins, yolk sac, yolk stalk or vitelline duct with vitelline vessels, and connecting between intraembryonic xylem and extraembryonic xylem. During the further development, amniotic cavity enlarged rapidly at the expense of the chorionic cavity, and amniotic begin to envelop the connecting and yolk sac stalk, crowding them together and giving rise to primitive umbilical cords. But I want to detail, because some things is depend of the development of the GI tracts. Around the 6th week of this gestation, the intestinal loop coming out from the abdominal wall into the chorionic cavity, and we say that this is a physiological herniation. This herniation is temporary. It's temporary events, and after the 4 to 5 weeks, the intestinal loop coming back to abdomen, and when its physiological herniation is finished, the vitelline duct and yolk sac are degenerated. It means that this part are degenerated, and when its herniation is finished and when the degeneration is happen in the vitelline duct and yolk sac, as a result of expansion of amnion cavity or amnion membrane, the chorionic cavity is obliterated. It means that amnion membrane coming to direct contact with the chorionic plate, and this cavity is disappear. Okay, as a result, the amnion cavity press the connecting stalk. Here you can see this part is coming back, allantois is degenerated, and only this part is remain and be narrow and making the umbilical cord. Finally, we say that the umbilical cord developed from the connecting stalk and contain 2 artery and 1 vein that's surrounded by a Wharton jelly. This tissue, which is rich in the protoglycans, functions as a protective layer for the blood vessels. The walls of the arteries are muscular and contain many elastic fiber, which contributes to a rapid constriction and contraction of the umbilical vessels of the cord is tied off. At the end of pregnancy, a number of changes that occur in the placenta may indicate a reduced exchange between the 2 circulations. Okay, and in the end of the pregnancy, we have a change in the placenta. We have 4 changes. One of them is increase in fibrous tissue in the core of the villus. The second change is thickening of basement membrane in fetal capillary. The third one is obliterative change in small capillaries of villi. And the final change is deposition of fibrinoid on the surface of the villi in junctional zone and in the chorionic plate. And finally, the cotyledon then assumes a whitish appearance, and this is a main reason for the end of pregnancy. We say that this is the changes at the end of pregnancy. Another thing that is important about the amniotic fluid, as you know, amount of amniotic fluid in the normal embryo approximately around the 37 or 38 week of the gestation is about 1,000 milliliters, 800 to 1,000 milliliters in the end of the pregnancy, but it's derived, this fluid mainly derived by maternal bloods, and small amount of fluid is secreted by the amniotic cells. The amount of fluid increased from approximately 30 milliliters at the 10 weeks of gestations to 450 milliliters at 20 weeks, and finally, as I told you, received to the 800 to 1,000 milliliters at the end of the pregnancy. But what's the role of the amniotic fluid? Amniotic fluid has three main roles. One of them shock absorb, prevents adherence of embryo to amnion, and allow for fetal movement. The volume of amniotic fluid is replaced every 3 hours. From the beginning of the 5th month, the fetus swallows its own amniotic fluid, and is estimated that it drinks about 400 milliliters a day, about half of the total amount. Fetal urine is added daily to amniotic fluid in the 5th month, but this urine is mostly water because the placenta is functioning as an exchange for metabolic wastes. Okay, sometimes we have some abnormality during the formation of the umbilical cord. The one of them is amniotic bond. As you see in this picture, tears in the amniotic result in amniotic bond that may be in circle part of the fetus, particularly the limb and digit amputation. You can see here the amputation in the lower limb. Unfortunately, origin of the bond is unknown. Another abnormality about the amount of the amniotic fluid. We have two kind of abnormality about the amount of the amniotic fluids. One of them, hydramnios or polyhydramnios, is the term used to describe an excess of amniotic fluid, approximately about 1,500 to 2,000 milliliters. Whereas oligohydramnios refer to the decreased amount, less than 400 milliliters. Both conditions are associated with an increase in incidence of birth defect. Primary causes of hydramnios include idiopathic case, maternal diabetes, and congenital malformation, including central nervous system disorder and gastrointestinal defect that prevent the infant from swallowing the fluid. But oligohydramnios is a rare occurrence that may result from the renal agnesia or renal agenesis. It means that the kidney is not developed. The lack of fluid in the amniotic cavity may constrict the fetus, or there may be too little fluid for the fetus to breathe into the lungs, resulting in lung hypoplasia. Another thing is premature rupture of the membrane. Refer to rupture of the membranes before uterine contractions begin and occur in 10% of pregnancy. Preterm premature rupture of the membrane occur before 37 completed week of pregnancy, occur in the 3% of pregnancy, and is a common cause of the preterm labor. The causes of the preterm premature rupture of the membrane are unknown, but risk factors include a previous pregnancy affected by prematurity, black race, smoking, infection, and severe polyhydramniosis. And final point and final things that I want to talk about, the placenta is a placenta or fetal membrane in twine. The frequency of pregnancy, multiple gestations, it means, for example, twins, triples, has increased substantially in recent years and now occur for over 3% of all live births in the United States. We have two kinds of the twins that I want to talk about. It's in here. One of them dizygote. Approximately 90% of twins are dizygotic or fraternal, and their incidence increase with maternal age, doubling at age 35 years old, and with fertility procedure including assisted reproductive technique. They result from the simultaneous shedding of two oocytes and fertilization by different spermatozoa. It means that we have a two oocyte, in ampullary region, and these two oocytes are fertilized by two sperm separately. They may or may not be of different sex. The dizygote implant individually in the uterus, and usually each develops its own placenta, amnion, and chorionic cycle, like this one, the A1. Sometimes, however, the two placentas are so close together that they fuse similarly. The walls of chorionic sac may also come into close opposition and fuse. Here you can see the fusion between the chorionic sac. Occasionally, each dizygotic twin possesses red blood cells of two different types. We say that erythrocyte mosaicism, indicating the fusion of the two placenta was so intimate that red cells were exchanged in this position, in the B position. Another one is a monozygote twins. The second type of twins, which develop from the single fertilized ovum, is monozygote or identical twin. The rate for monozygote twins is 3 to 4 per 1,000, and they result from the splitting of the zygotes at the various stage of development. You can see that splitting of zygote in the various stage of development. Splitting of zygote usually occur in early sometimes that you see the picture. The earliest separation is believed to occur at the two cell stage here, in this stage, in which case two separate zygote develops. You can see two zygote is developed. The blastocyst implant separately, and each embryo has its own placenta and chorion. You can see own placenta and chorion. Although the arrangement of the membrane of this twin resemble that the zygote twin, that two can be recognized as partners of a monozygote pair by their surrounding resemblance in the blood groups, fingerprints, sex, and external appearance such as eye and hair color. Splitting of zygote usually occurs at the earlier blastocyst stage. In here, this is blastocyst stage. The second condition is splitting in the blastocyst stage. The inner cell mass is split in two separate group of cells within the same blastocyst. We have a two separate inner cell mass. The two embryo have a common placenta and common chorionic cavity here, but separate amniotic cavities. In the rare cases, the C position, the separation occurs at the bilaminar germ disc stage, just before the appearance of primitive stick. This method of splitting results in formation of two partners with a single placenta and common chorion and amniotic sac. Here we have a common amniotic sac. Although the twine have common placenta, blood supply is usually well balanced. Although triplets are rare, about 1 per 8,000 pregnancy, births of quadruplets, quintuplets, and so forth in rare. Finally, I want to talk about some clinical correlates. Abnormalities associated with twines. Twine pregnancies have a high incidence of prenatal mortality and morbidity, and an increased risk for preterm delivery. Approximately 60% of twins are born preterm and also have a high incidence of being low birth weight. And the one of the important abnormality, as you see here, that is vanishing twine. The term of vanishing twines refers to the death of the one fetus. This disappearance, which occurs in the first trimester or the early second trimester, may result from the resorption or formation of the fetus papyrusus. Here, fetus papyrusus. Another problem leading to increased mortality among twine is twine transfusion syndrome, which occurs in 15% of monochorionic monozygotic pregnancy. In this condition, placental vascular anastomosis, which occur in a balanced arrangement in the most monochorionic placentas, are formed so that the one twine receives most of the blood flow and the flow to the other is compromised. As a result, one twine is larger than the other. The outcome is poor, with death of both twines occurring in the 50% to 20% cases in here. The last abnormality I want to talk about about the adhesion of the embryo. As you see this picture, occasionally monozygote twins are connected only by a common skin bridge or by a common liver bridge. The type of the twine formed depends on when and to what extent abnormality of nodes and streak occur. This is a thoracopagus twine and this is a craniopagus twines because they're connected by cranial regions. Misexpression of genes such as goscoid may also result in conjoined twines. Many conjoined twines have survived, including the most famous pair, Chang and Eng, who were joined at the abdomen and who traveled to England and United States an exhibition in mid of 90s. Finally, finally, you can see that the separation of the twines is depend of the common tissue. If they joined by only the skin, the separation is very easy, but if they have a common important structure like a liver and lung, the common blood vessels in the head, the separation is not happen and is difficult, and if you're doing a separation, maybe they both of them death. Okay, and finally I want to talk about the preterm birth or premature infants. This condition occur in approximately 12% of the births in the United States and is leading cause of infant mortality and also contributes significantly to morbidity. The risk factor for the premature infant include previous preterm birth, black race, multiple gestation, infections such as periodontal disease and bacterial vaginosis, and low maternal body mass index. And in the end of this chapter, I suggested please read the Longman Medical Embryology or the Human Development of the Human Development by Kittel Moore, or Human Embryology of Lawson, the best books for the more readings. And this is a summary of the preterm parturition. Is not need for you, only for more study. In the last session that I want to talk about the congenital abnormality in the embryo. Thank you. See you in the next lectures.